Xin chào các anh chị. I'm Dr. Eric Krakauer speaking to you from Harvard Medical School in Boston. I would like to thank the organizers of Vietnam's National Cancer Conference for kindly inviting me to speak, and I'm sorry I cannot be with you in person. For the next few minutes, I will speak to you about integration of palliative care with cancer immunotherapy. I have no income from a private industry. So in the next few minutes, I'd like to talk to you about immune-related adverse events and how palliative care can help to reduce the risks and potential harms of cancer immunotherapies and improve patient outcomes. I think you're all very familiar with immune checkpoint inhibitors, so I won't describe them in detail, given how that I have just a few minutes. As you know, the immune checkpoint inhibitors disrupt the bonding between the T cells and the cancer cells. Immune checkpoint inhibitors are now used for many different cancers, as you know, from melanoma. Ipilimumab was one of the first, and now nivolumab for multiple different cancers, including Hodgkin's disease, esophageal cancer, bladder cancer, gastric cancer, renal cell cancer, colon cancer, pembrolizumab, also for a variety, and then some of the newer immune checkpoint inhibitors. So what are the potential burdens of immune checkpoint inhibitors? Well, they activate the immune system, and this can result in so-called immune-related adverse events that are quite different from the side effects of chemotherapy. The immune response may attack normal tissues, and the inflammation itself can be harmful. And studies have showed that there can be very delayed or chronic immune-related adverse events, and that immune-related adverse events can be acute on chronic, meaning they can become acute weeks or months after treatment. I apologize for how small the writing is on this slide. It calls attention to the immune-related adverse events based on their prevalence. So the ones that have a greater than 10% incidence are written in red. In the musculoskeletal system, they're particularly arthralgias and myalgias. In the gastrointestinal system, diarrhea, colitis, and hepatitis all occur with greater than 10% incidence, I should say, not prevalence. Also, uveitis of the eye, hypothyroidism, and the most serious is typically pneumonitis, the skin conditions that occur that have an incidence of greater than 10% are rash and pruritus. So compared to standard chemotherapy, anti-program death 1 or anti-program death ligand 1 resulted in increased incidence of hypothyroidism, pneumonitis, colitis, hypophysitis, and musculoskeletal pain. These are the gradations of toxicity, 1 being mild, 5 being death, and 3 and 4, or grades 3 and 4, are quite serious. The overall incidence of immune-related adverse events of any grade has been found to be around 66%, with grade 3 or 4 being 14%. And the most common grade 3 or 4 immune-related adverse events are fatigue, anemia, liver transaminase increase, pneumonitis, which is the most commonly is the adverse event that is most commonly leads to death, and colitis and diarrhea. There is a higher incidence of immune-related adverse events from nivolumab than from pembrolizumab, and PD-1 inhibitors tend to have a higher incidence than PD-L1 inhibitors. This CT scan is from a patient 25 days after her first dose of immunotherapy and 5 days after the second dose. She went to the emergency department with a severe respiratory distress. So this slide shows the standard toxicity management depending on grade, the grade of the immune-related adverse events. With grade 1, immunotherapy is continued, symptoms are treated, and patient is closely monitored. And I would just point out that treatment of symptoms is really what palliative care is. It's not important whether we call it palliative care or something else, but it just shows how symptom relief, or what some would call palliative care, is a standard part of immunotherapy for cancer. For grade 2, again, symptoms are treated, immunotherapy is delayed or paused until the symptoms are reduced to grade 1, and corticosteroids can be considered. And this is often when I have discussions with my oncologist colleagues, the decision of when to use corticosteroids, with the effort to try to avoid using corticosteroids to minimize so that the cancer fighting effect is not diminished, but also recognizing that the patient's comfort and life are both very important. And then with grade 3 and 4 immune-related adverse events, immunotherapy, of course, needs to be stopped, except sometimes with skin toxicities. Corticosteroid needs to be implemented and tapered slowly. Sometimes also second-line immunosuppression is needed for high-grade adverse events, and these are some of the immunosuppressants that are used. And this slide shows the most recent guidelines from various sources: the American Society of Clinical Oncology, the Society for Immunotherapy for Cancer, and the NCCN guidelines. So what are the palliative care needs? Well, prior to initiating immunotherapy, it's important and whenever there's a clinical change, a significant clinical change, it's important to explore the patient's or the family's understanding of the disease, to be sure that they understand the seriousness and the prognosis, and correct any misunderstandings. It's also important to understand the patient's values. Some patients are willing to tolerate very severe immune-related adverse events and to take high risks. Others are not. And based on this discussion of the patient's values, and in the setting of the clinical situation, there should be an agreement, ideally, on the goals of care, such as whether to pursue immune complex inhibition, immune checkpoint inhibition at all, whether to pursue other cancer treatments, or whether to focus on comfort, and also an agreement on how life-threatening complications should be managed. Ideally, there should be long-term follow-up in the community. And this might involve some education for staff at provincial or district level, possibly even community level, on immune-related adverse events. So if a patient goes home who has received immune complex inhibitor therapy, it would be good for staff at lower levels to be able to recognize possible immune-related adverse events that may need to be treated. Of course, symptoms need to be treated, whether it's pain or dyspnea, diarrhea, anxiety, and psychological and social support are always important for patients with either for symptoms of cancer or immune-related adverse events. As I mentioned, there can be acute on chronic immune-related adverse events, namely symptoms that may pop up, that may occur weeks or months after treatment. Sometimes they may be severe. And again, the toxicity management guidelines should be followed, but there should be, when there's a major change, another re-examination of goals of care. Of course, always discussion of benefits and disadvantages of corticosteroid therapy, and intensive symptom control and psychosocial support. For lack of time, I will skip this case and just spend a few minutes on CAR T-cell therapy, which is a new therapy, which I suspect will arrive in Vietnam soon if it's not already there. This stands for retroviral modified chimeric antigen receptor T-cell therapy. So how are T-cells modified? Well, they're taken out of the body using a viral vector. The chimeric antigen receptor is introduced into the cell, which is then expressed on the T cells, which are then reintroduced into the patient. Schematically, it looks like this. T cells are harvested, then they are in the laboratory infected with by a virus, which carries the information to produce the chimeric antigen receptors. The cells that are producing those receptors are then expanded, there's quality control, and then those cells are reintroduced into the patient. The Food and Drug Administration in the US initially improved CAR T-cell therapy for lymphomas, acute lymphocytic leukemia, and multiple myeloma, but there are now studies ongoing with multiple solid tumors, including glioblastoma, neuroblastoma, breast cancer, non-small cell lung cancer, mesothelioma, ovarian cancer, renal cell cancer, and sarcomas. So what are the toxicities? There are two. The first is cytokine release syndrome, which looks like septic shock. It may occur somewhere between 2 to 3 days typically. It typically lasts about a week, and it can range in severity from just mild symptoms to life-threatening shock with multi-organ system failure. This slide shows the grades of cytokine release syndrome and the typical symptoms: fever, hypotension, which can be mild or severe, and hypoxia, which can be mild or so severe as to require mechanical ventilation, intubation and mechanical ventilation. The second major type of toxicity from CAR T-cell therapy is so-called immune effector cell associated neurotoxicity syndrome, or ICANS. It typically occurs 4 to 6 days after treatment, may last a couple of weeks, and it produces a toxic encephalopathy that may consist of headache, confusion, delirium, aphasia, seizures, and sometimes cerebral edema. It may occur with or without cytokine release syndrome, and it involves capillary leak, endothelial activation, disseminated intravascular coagulation, and a breakdown of the blood-brain barrier. The American Society of Transplantation and Cellular Therapy has guidelines for grading ICANS, which I've shown here, the so-called ICE score, or immune effector cell encephalopathy score, ICE score, and another grading system also from the ASTCT. The response to both of these toxicities is shown here. It's depending on the grade of toxicity with immunosuppression and or steroids, sometimes separate, sometimes together. But very importantly, again, palliative care should be integrated, especially when there's severe toxicity. And palliative care consists, as always, of symptom relief, psychosocial support, and assistance with goals of care decisions. It's part of supportive care, and it's especially needed by patients with severe toxicity and their families. So to summarize, palliative care should be integrated with immunotherapies in hospitals, and staff in the community also should be able to recognize immune-related adverse events. Thanks to my Harvard colleagues for these slides, and also to my Vietnamese colleagues, the organizers of this conference, the leaders of the National Cancer Hospital in Hanoi, and the Hoi Hop Trong Sok Sam Ye Vietnam. Thank you very much.